Opiates are drugs derived from the opium of a poppy plant. They can be natural or synthetic, prescription or illegal, and common names are heroin, Vicodin, morphine, and fentanyl. They're highly addictive. Opiates trigger receptors in the brain to release a rush of dopamine, which causes a feeling of euphoria. Tolerance to these drugs can be built quickly, even when it's a prescription, which can lead to further withdrawal symptoms.
So, what are the risks of opioids? Side effects can include drowsiness, mental fog, nausea, and constipation. Opiates can also cause slowed breathing, which can also lead to overdose deaths. Other risks include dependence and addiction. Roughly 21% to 29% of patients prescribed opioids for chronic pain misuse them, and between 8% to 12% develop an opioid use disorder. An estimated 4% to 6% who misuse prescription opioids transition to heroin, and about 80% of heroin users first misuse prescription opioids. Comorbidity between substance use disorders and mood and anxiety disorders is common, with 1/3 to almost half of the general population meeting criteria for comorbidity at some point in their lives.
According to DSM-5, a person can be classified as having opioid use disorder if they match 2 of the following 11 criteria over a continuous 12-month period. Number 1, opioids are taken longer or in larger amounts than what was intended. Number 2, the person desires opioids persistently or is unable to cut down use. Number 3, they spend a lot of time trying to get, use, or recover from opioids. Number 4, they experience an intense desire or urge to use. Number 5, their usage results in a failure to perform usual roles in work, school, or home. Number 6, they continue to use opioids despite the act causing recurrent disruptions in their social or interpersonal lives. Number 7, the use results in a reduction or elimination of work, leisure, or social activities. Number 8, they continue to use opioids in situations that are dangerous to their physical health. Number 9, they continue usage despite the fact that this has caused or worsened physical or psychological problems. Number 10, they have developed a tolerance to the substance. Or number 11, they have developed opioid withdrawal symptoms.
There are several types of screening tools and assessments that primary care providers and behavioral health care providers can use to assess substance abuse and opioid use disorder. One is the TAPS tool. This is a 2-part assessment. The first screens for adults who have used substances in the past 12 months, and the second part is a brief assessment that focuses on the 3 past months of use for individuals who screen positive from the first part. Another tool is the opioid risk tool. This is used with adults who are already taking prescription opiates for chronic pain and can be used to determine if they're at future risk for abusing substances. There's also the NIDA drug screening tool. This is useful for clinicians to identify substance use in adults and can be helpful in identifying which patients may need referral to specialty treatment.
Opioid use disorder treatment. Opioid use disorder is commonly treated with medicated assisted treatment, otherwise known as MAT, which typically offers pharmacotherapy in combination with counseling and/or behavioral treatments. Common pharmacological interventions are methadone, buprenorphine, naltrexone, and Suboxone. Behavioral interventions can either be outpatient or inpatient/residential, depending on the needs of the patient and the severity of the disorder. Treatment can include drug counseling, motivational interviewing, and cognitive behavioral therapy.
Two common medication-assisted treatments that are used to treat opioid use disorder are methadone and Suboxone. All medications used to treat opioid use disorder are intended to reduce or eliminate withdrawal symptoms and block the effects of opiates when used. Methadone specifically is used to reduce withdrawal symptoms and cravings. It can be prescribed in a wafer, a liquid, or a tablet form. This can be a risky treatment because patients still need to slowly detox from methadone when they feel they don't need it anymore. And it has the effects of opiates at a moderate dosage. With Suboxone, that's a blend of two other opiate treatment drugs, buprenorphine and naloxone. This is a partial agonist, partial antagonist, meaning that it has the effect of opiates to some degree, but it also has opiate blockers. This drug works to stabilize the brain and wean the client off of more serious opiates like heroin. Buprenorphine can be prescribed by a physician, and it decreases withdrawals and cravings. It also reduces the risk of overdose. It's a partial agonist, meaning it has some opiate effects, but overall is safer than methadone. Due to the drug being long-acting, it may not need to be taken every day. Naltrexone is different than methadone and buprenorphine in that it blocks the receptors and prevents the patient from feeling high or euphoric if they do relapse. There's no potential for addiction. A patient must be off other opiates for 7 to 10 days before being prescribed naltrexone. Behavioral interventions for a patient with opioid use disorder is typically provided in an outpatient treatment setting or an inpatient setting. Whichever program, the objectives are the same. They're working to modify attitudes and behaviors related to drug use, increase healthy living skills, and abstain from using substances and relapse prevention. One key difference of an outpatient treatment program is that the patient is not living in the facility where they're receiving services. They may be going to the facility several sessions per week. The services may be intensive at first, and they may transition to less frequent sessions over time. Whereas in an inpatient or residential treatment, the patient is living in the facility. It's typically a better option for those with more severe needs. They may start off in a short-term or a detoxification facility and then move into a therapeutic community, which can be as long as 6 to 12 months. Some time frames are different. And then a patient with opioid use disorder may end up living in recovering housing as they transition back to independent life in the community. Whether the patient is in inpatient or outpatient treatment, they're likely going to be using a combination of therapeutic approaches. Therapy and counseling services provided to patients with opioid use disorder may include individual, group, or even family or couples counseling, or a combination of several of those. There are several types of therapeutic approaches. Two commonly used ones include cognitive behavioral therapy and motivational interviewing. Cognitive behavioral therapy can help individuals identify their thought patterns and change their behavior, and this can be helpful as they plan to avoid situations that may trigger their drug use and build coping skills for situations that are unavoidable. And then through motivational interviewing, individuals can determine what's their motivation for change, their readiness for change, and develop a plan accordingly. Likely a combination of therapeutic approaches will be used.
As can be seen in the pie charts, in 2017, opioid use disorder disproportionately affected white males between 18 and 34. This has been described as an effect of income and prescription tendencies of primary care physicians, But it is in the government response that the real social justice issue is revealed. In the 1980s, as part of the War on Drugs legislation, tough penalties were awarded users of crack cocaine that resulted in a disproportionate number of young black males being imprisoned. In comparison, what has been called the opioid epidemic is considered a national health emergency and is not subjected to the disproportionate amount of young white males to the same criminalization. While this discrepancy may be attributed to the legal status afforded prescription opioids versus crack, it is also clear that the difference in victim characterization is another example of systemic racism that accounts for the current overrepresentation of Black Americans in private, nonprofit prisons.
One case example of a patient with opioid use disorder involves Roy. Roy is a 26-year-old white male referred by his physician for his use of opiates. He has been using heroin since he was 19 and has been increasing his usage the past 6 months due to being homeless. Roy is concerned about his drug use, but states he can't quit because the withdrawal is awful, and since he has been homeless, it is all he can think about. Roy also has been diagnosed with schizoaffective disorder and reports that he hears loud voices that can get worse depending on his heroin use. He reports having extreme depression, suicidal thoughts, and anxiety on a day-to-day basis. During the assessment, Roy is found to meet the criteria of opioid use disorder. The social worker advises him on medical treatments including methadone, which could help ease withdrawal symptoms and make it easier to stabilize his mental health and living situation. Substance abuse counseling was also recommended. The client agreed to the methadone treatment, but had concerns over being able to afford it. The client was open to counseling and recovery, but stated being nervous around new people. The social worker used motivational interviewing to ease his anxieties about treatment and inform the client about state-funded programs that don't have a cost. The social worker used psychoeducation to assist Roy in understanding treatment steps. The social worker walked him through the intake process at the methadone clinic, the effects of methadone, and how methadone aids in stopping the use of opiates. The social worker arranged an initial intake at the methadone clinic for the client. The social worker also arranged an initial appointment at a state-funded substance abuse counseling clinic that can fund the methadone treatment.